And that's against the next topic, which is the diagnostic differentiation difficulty between tuberculosis and Crohn's disease, to be dealt with Professor C Ghoshal.
Thank you so much. It is a pleasure for me to come back home once more, and I thank Indian Association of Surgical Gastroenterology for giving me this opportunity. Obviously, you are all surgeon, and I'm a minority here. I'm a medical person. I'll be talking about tuberculosis versus Crohn's disease versus unclear diagnosis, how we manage the patient. Let me tell you, when we say tuberculosis versus Crohn's, and the third is unclear diagnosis, what else could be the unclear diagnosis? The closest differential diagnosis of Crohn's is Behçet's disease. But fortunately, Behçet's is very, very uncommon. In fact, now we have a patient in whom we suspected Behçet's, and he is in our ward. So therefore, I will not cover much on Behçet's. I will cover only on CD and TB. And CD and TB is a difficult situation, because if you think this is a patient of Crohn's disease and start him on therapy for Crohn's such as corticosteroid, biological or other immunosuppressive, and he is not Crohn's, he has tuberculosis, he will do major harm to the patient. On the other hand, if you give anti-tubercular to every patient, obviously you are delaying the diagnosis of Crohn's, and therefore their disease will progress. Theoretically, even anti-tubercular treatment can lead to response in Crohn's disease, the mechanism of which I do not want to go because 10 minutes I have. Now, Indian Crohn's disease consensus, we said the diagnosis of Crohn's disease should be based on a combination of clinical, endoscopic, histological, radiological feature with satisfactory exclusion of tuberculosis. Now, let me tell you, this satisfactory exclusion of tuberculosis is very difficult. As Dr. Ashok just said now, that is very difficult, and many a time we land up empirically actually giving anti-tuberculosis drug. And in fact, we also do that. But can we be wiser so that we limit empirical therapy as much as possible and only give based on a higher probability? Now look at these. These are two large series of Crohn's disease and tuberculosis from India. So one series on the left side is of tuberculosis, and on the right side is of Crohn's disease. These are multi-center series involving IPGMER Calcutta, SGPGI Lucknow, CMC Vellore, and AIIMS New Delhi. And I do not want to list all the clinical presentation, but you will realize their clinical presentation is very close. Like they will present with diarrhea, maybe bleeding, such as obscure gastrointestinal bleeding, recurrent subacute intestinal obstruction, intestinal colic like pain, some having systemic symptoms. So clinically, they look very similar. Now, many of them, almost 70% patients, both of Crohn's and tuberculosis, their involvement will be ileocecal. And remember one thing, ileocecal involvement occurs in many other diseases. I will not read all the list, but the major one, as you can see on the left side, are tuberculosis and Crohn's disease. Now, this is how we differentiate CD from TB, and it is an exhaustive table. Now, obviously, I am not going to read through whole of this table, but what you have to realize is you have to take a very good clinical history, do a good physical examination, because there could be multiple clues. For example, if a patient said, I have diarrhea which exacerbates following non-steroidal and anti-inflammatory drug, I am probably dealing with a patient of Crohn's disease. If a patient says, I have a brother who has ulcerative colitis or Crohn's disease, I am probably dealing with a patient of Crohn's disease, because we all know 10 to 15% of them have family history. So there are multiple things that I have listed here. For example, perianal lesion is very suggestive of Crohn's and is very uncommon in tuberculosis. Skip lesion is very suggestive of Crohn's, relatively less common with tuberculosis. So there are so many things that I have listed here. What we are doing by all this? We are increasing our probability of one over the other. So in clinical medicine, we go by probability. The probability is 80%, you're often right. If your probability is 100%, it doesn't happen in real life, particularly in this situation, differentiation between CD and TB. So I'll again skip this table and this table. Now what happens is, look at this large series from AIMS. What they did is, this is a publication from in American Journal of Gastroenterology. They took a lot of patients of tuberculosis and Crohn's disease, and they tried to see, can we differentiate between these two by simple features, and they found if blood is present in stool, it is unlikely to be tuberculosis, but more likely to be Crohn's disease, because tuberculosis often have end arteritis. Therefore, bleeding per rectum or frank bleeding is uncommon. On the other hand, as you can see here, weight loss was greater in tuberculosis patient, involvement of sigmoid colon was lesser in tuberculosis, and focally enhanced colitis was lesser in tuberculosis. So two important clinical features are bleeding per rectum or frank bleeding is less common with tuberculosis, and weight loss is more marked in tuberculosis. This is radiology, and truly speaking, all the radiological thing that you can see occurs in both. But let us look at this particular thing. I'll show you one. So this is a capsule endoscopy feature. Can you recognize what is this? This is capsule endoscopy, and you can see something inside. What is that? Yes, very right. So what is stone called in the intestine? Enterolith. So this is an enterolith, and the enterolith has been typically described in tuberculosis. But why should enterolith not occur in Crohn's disease? Because Crohn's has more chronic stricture than tuberculosis. And this is capsule endoscopy demonstration of enterolith in a patient of Crohn's disease. So fortunately now, earlier small bowel was a black box. We, the gastroenterologists, did not have avenue to examine the small bowel, but we have multiple technologies now, such as single balloon enteroscopy, double balloon enteroscopy, spiras, motorized spiras, and capsule endoscopy. And most of these features that I have shown here are picture of capsule endoscopy. So question is, let me tell you, what is the best way to diagnose tuberculosis? If I can get acid fast bacillus. But in real life, do you get that? You get in less than 2% patient. If you are lucky, if you use special technologies, which I'll tell now, you can increase the yield up to 10%. That means in 90% you can't guess A, B in small bowel or large bowel. Why? Because small bowel and large bowel, this is typically a paucibacillary disease, and if the density of the bacillus is less, you will not pick up by endoscopic biopsy. So therefore, how to increase the yield? Biopsy by well technique, where I put a biopsy forceps again and again in one location, endoscopic fine needle aspiration cytology, biopsy cross smear or brush cytology, backtech culture, DNA by PCR, and now we have gene expert, which not only gives me the DNA, but also gives me the nucleotide sequence, which is associated with resistance to rifampicin. So these are the ways to increase the yield, but still not great. Anti-Saccharomyces cerevisiae has been used by many people earlier, but let me tell you, there is a word of caution. What is anti-Saccharomyces cerevisiae antibody? We all eat bread, and bread contains Saccharomyces cerevisiae. It is a fungus. If you have a damaged small bowel, the fungal antigen goes below the submucosa, and you develop antibody against this fungus. There was one study published in Diseases in Colon and Rectum in 2003 on 11 patients of tuberculosis and a large number, more than 50 or 60 Crohn's disease. They found ASC antibody was there in 50% Crohn's, but out of 11 only one tuberculosis, and therefore the market was full of ASC antibody, and people were using ASC antibody to differentiate between TB and Crohn's. Look at the beauty of research, why you should be doing research. These are two studies, one published from AIMS and one from SGPGI. What we did is we tried to look at anti-Saccharomyces cerevisiae antibody in tuberculosis patient and Crohn's patient, and we found it occurs in equal frequency, which is quite expected because the small bowel is damaged in TB, small bowel is damaged in Crohn's, therefore the antigen will go inside and will produce antibody. Now what you will do then? What happens is, look at the left-sided box. It says, try to see, is your patient having tuberculosis? How to do that? Previous TB, TB contact, abnormal chest X-ray, HIV positive, positive test for latent TB such as, let us say, quantiferon TB gold, Mantoux test, interferon gamma assay, TB lesion on colonoscopy, because we know colonoscopy you have a lot of cobblestoning such as Crohn's. On the other hand, there are certain tubercular characteristics like circumferential ulcer and all those tuberculosis. TB lesion on histology. What is the histology TB lesion? Large granuloma, confluent granuloma, caseation. These are features of TB granuloma. Crohn's granuloma is non-confluent granuloma, discrete granuloma, granuloma less than 5 micra in size, and non-caseating granuloma. And now you consider, maybe I'm 60 to 70% right that I'm dealing with tuberculosis, give ATT. But you cannot be 100% sure this is TB. On the other hand, if there is no past TB, no TB contact, normal chest X-ray, HIV negative, negative TB test, CD on endoscopy such as cobblestoning, which is called Lee criteria, CD lesion on histology, I told you Pulimuth criteria, give CD therapy on the first go. Now then you follow up the patient, and when you follow up, very important, 2 months later you repeat all the investigation which gave you the diagnosis. Your diagnosis could be on colonoscopy, it can be on enterography such as CT or MR enterography, it could be inflammatory marker. Use very commonly fecal calprotectin, because what we do is fecal calprotectin is simple non-invasive test on stool. It suggests inflammation in the colon. If I find after 2 months of ATT fecal calprotectin is very high, on colonoscopy I find lesions are still there or they have become more florid. If I find new lesion has developed, for example, a fistula has developed, I am dealing with Crohn's. Now, if you treated him as TB, we have no right to stop the TB therapy in 2 months. We have to complete 4 more months, because this is for public interest. We do not want to develop resistant bacillus or a multi-drug resistant bacillus. Therefore, I will give 4 months more ATT therapy, but I will initiate anti-CD therapy. So the same is depicted here, but I know I have now 10 seconds or maybe 12 seconds. I will not read it in great detail, but let me tell you, if you have a stricture and the stricture is not passable, it is a tight stricture, patient is developing subacute intestinal obstruction again and again, and even endotherapy is failing. I know you are surgeon, you will say, why do you want to do endotherapy? We are not interested to do endotherapy. If Dr. Ashok takes over, I will immediately give this patient to Dr. Ashok and say, please operate, because I know in a stricture patient, if he can operate early, will get greater relief and more sure relief of the patient. But if Dr. Ashok says, no, patient is very malnourished, low albumin, he has a lot of comorbidities, why don't you do an endoscopic dilation? We'll do that. Now, what is the treatment for TB? Again and again, TB is ATT. But question is, in abdominal tuberculosis, should you use 6 months or 9 months? Because of shortage of time, I did not show you data. We have completed a study and published that study about 5 or 6 or 8 years ago. This is a study on 210 patients, 6-month therapy versus 9-month therapy. This was initiated by RNTCP, that is Revised National Tuberculosis Control Program, Ministry, Government of India, because they wanted to reduce the cost of therapy and also see the efficacy. And we found 6 months is as good as 9 months even in GI tuberculosis. Crohn's disease, you will use immunosuppressives such as azathioprine, 6-mercaptopurine, methotrexate, or biologicals. We have now multiple biologicals such as infliximab, adalimumab, golimumab, vedolizumab, ustekinumab, tofacitinib, and so on. Obviously, tofacitinib does not work in Crohn's disease. It works only in ulcerative colitis, but we have now others such as upadacitinib, which works in Crohn's disease. I do not want to burden your memory with all these, but these are biological. Now question is, if you give biological to a Crohn's patient, are you curing the disease or are you doing a great job? Look at this data, which is Creole study. Many of these patients in long-term follow-up, biological may fail, stricture may require surgery. So therefore, we are not competitor. We want our patient to have the best therapy by combination of surgeon and physician. So I'll skip here and take up any question if you have. Thank you so much.
Wonderful speech, sir. Any questions?
So this is Partharthi from Hyderabad. This is regards two situations which we surgeons encounter this dilemma. One is in an appendicectomy where you have a dilemma of Crohn's versus tuberculosis. After the appendicectomy, patient is absolutely all right, colonoscopy is normal. But you have a specimen which has given you this dichotomous diagnosis. You are not sure which is what. And in that case, how would you go ahead? Second, in same scenario with perianal fistula. When you do a fistulectomy and we routinely send it for biopsy, there are many occasions where we find granulomas, but the pathologist is not able to comment further. Upper J, lower J endoscopy also does not show any other lesions. Patient is cured for all practical purposes. These two groups of patients after our surgery are absolutely fine, except the biopsy report has a confusing report.
Very important point that you have raised. Let me tell you, tuberculosis of appendix is uncommon. So isolated appendiceal tuberculosis is uncommon. Giving ATT therapy based on a histology report, unless pathologist tells me AB is there, I would not give. What I will do is that follow up the patient, simple, I'll do CRP, ESR, maybe I'll do a MUN2, and if I get a very strong positive MUN2, if ESR remains very raised, patient becomes symptomatic, I may consider. Similarly, if you are talking of Crohn's, in Crohn's we have better method to see whether we are dealing with an active Crohn's disease or not. I'll do periodical fecal calprotectin. Fecal calprotectin, if it is normal, below 50, you can rest assured, don't start therapy for Crohn's, because Crohn's is a lifelong disease. Once the therapy is started, these therapies are not without toxicity, without cost, so therefore don't give. Remember, granuloma is a body's response to any infection, inflammation and other type of injury. Anything which chronic can lead to granuloma. Therefore, in fistulous tract you got granuloma, it is not caseating, it is not having AFB, I will not again give a therapy for ATT or Crohn's. The Crohn's will surely with time show that there are other features on colonoscopy, maybe new lesions are developing and fecal calprotectin is raised. Otherwise, if you get an isolated histology report, you can follow up the patient periodically, do other marker periodically, don't institute therapy unless AB is present.
Thank you.
Yes.
Similar thing, we have a conundrum we've had is ulcerative colitis patient suspected who's been on steroids and all that. We do a subtotal colectomy and now want to do close the thing and do a pouch subsequently. The biopsy report shows granulomas.
Very good question. Let me tell you, biopsy granuloma occurs in ulcerative colitis in 5% patients. So UC can have granuloma in 5%, whereas CD have granuloma in 25 to 50%. That this means that granuloma is not sine qua non of Crohn's disease. Now, these are the patients where you tell indeterminate colitis. You don't classify them as ulcerative colitis. You don't classify them as Crohn's disease, but you say indeterminate colitis because there are features of Crohn's as well as UC. Carefully follow them up. People have shown if you are dealing with a Crohn's patient or indeterminate colitis patient there, if you do surgery, recurrence will be more common, pouchitis will be more common, maybe new lesion will develop more often. That's why many of time surgeon like Dr. Ashok will say, Dr. Ghoshal, this is looks like Crohn's patient or indeterminate colitis. I'm not pushed to the corner. Why do you want me to do surgery? So therefore, I would say that it is not sine qua non of Crohn's, but be careful. If you do a sort of restoration, you may get pouchitis, but if you get, we have other methods to manage pouchitis. If the patient wants restoration, and if fecal calprotectin is normal, if colonoscopy doesn't show frank disease, you can go ahead and do a restoration in that patient also.
So that's a question. Will fecal calprotectin in this situation be useful if the colon is out actually?
No, actually fecal calprotectin does not mean fecal calprotectin only. If you have put a stoma, I'll do calprotectin in the stoma bag. You know why? That it actually tells me, is the mucosa of the bowel inflamed? So if the mucosa is inflamed, whether it is a small bowel mucosa or colonic mucosa, I will get calprotectin raised. Right. So that is a good marker both in the feces as well as stoma bag.
Thank you. Thank you.
Thank you.
Yeah, I just have probably something similar to what Dr. Pasaridi asked. Often we have a situation in which we operate for small bowel stricture. Intra findings were more suggestive of Crohn's in the sense there were two places strictures, so the dominant stricture was resected. There was also creeping fat, but post-operative biopsy was not suggestive of Crohn's and also not suggestive of tuberculosis. It's a descriptive biopsy report. So in those scenarios, whenever we have a combined discussion with medical gastroenterologists, so they are hesitant to start on Crohn's therapy without biopsy features suggestive of Crohn's. So
yeah, very important question again you raised. Let me tell you, Crohn's can be only fibrostenosing. The fibrostenosing will not have a lot of activity. Whenever we assess a Crohn's patient, we see the extent of the lesion. We see the type of lesion, whether it is penetrating, fistulizing or stricturing. And we see the degree of inflammation. The degree inflammation is told by CRP, ESR and fecal calprotectin. Now a patient of Crohn's can have a fibrostenosing disease without much inflammation and without fistula formation. These patients often have localized disease, they have a protracted course and dormant disease. The medical gastroenterology colleague will not usually start immunosuppression or biological if the fellow's fecal calprotectin is normal or if his CRP and ESR is not high, because it basically means this is a fibrotic, burnt out disease. It doesn't have active inflammation. There is no need for giving anti-inflammatory drug, but still this patient may be Crohn's disease. But there could be other situation. For example, somebody could be on chronically on NSAID, and NSAID can cause small bowel stricture. There could be idiopathic ulcer in the small bowel that can cause stricture. But for all practical purposes, if inflammatory markers are negative and patient is not symptomatic, there is a fibrostenosing Crohn's or another stricture due to other cause which does not require immunosuppressive or immunomodulator.
Thank you.
Okay, thank you so much.
If no more questions, we'll close. Thank you, everybody.